It's a wonderful lecture. Let's catch on the next talk because the time is late. Welcome, moderator, Professor Yo Chun Su. Professor, please.
Hi everyone, I am Yo Chun Su, a pediatric pulmonologist from Ida Hospital, Taiwan. And the other moderator is Professor Lai. He will hold the Q&A section. It's my great honor to introduce the speaker, Professor Raymond Orders. Currently, he is the Chief of General and Gastrointestinal Surgery, and also the Director of Minimal Invasive Surgery in University Hospital, Cleveland Medical Center, the United States. Professor Orders is a world-renowned surgeon and a distinguished expert in the field of diaphragm pacing. The diaphragm pacing has developed for more than 2 decades. This technology has helped many patients suffering from spinal cord injury, severe neurological disorders, and post-surgical patients. Today, Professor Orders will have a special speech. The title of the speech is Diaphragm Pacing Experience, the Growing Role in Pediatrics. Now, we start the speech by Professor Orders. Please start.
I'd like to thank all of you for having me speak this evening. I wish I could be in person. It'd be great to be at the 6th Annual Scientific Congress of the Asian Pediatric Pulmonology Society, the 23rd Annual Conference of the Taiwan Society of Pediatric Pulmonology and Critical Care Medicine, 12th Annual Scientific Congress in Pediatric Pulmonology from 3 places across the strait. Today, I'm going to be talking about my diaphragmatic pacing experience and a growing role in pediatrics. Conflict of interest is everything I'm talking about today was actually developed at my university with myself and researchers at Case Western Reserve University and University Hospitals of Cleveland. No other investigators had a conflict of interest. The problem, as we all know, is the increasing ventilatory burden, resource burden, morbidity. The COVID-19 pandemic highlighted this. We know prior to the pandemic, over 100,000 tracheostomies for fear to wean mechanical ventilation was performed in the United States each year. We know that 40% of the time on mechanical ventilation is spent weaning after the acute event. And this is really from ventilator-induced diaphragm dysfunction. 50% of diaphragm atrophy occurs in 24 hours. There's rapid conversion of type 2B muscle fibers. We know tracheostomies have inherent risks. Part of the solution is to maintain diaphragm strength and drive respiration with diaphragm pacing. Diaphragm pacing has been shown to decrease the 40% of the time the patients spend weaning by 60% in previous experience. The background is I spent 25 years in research on this aspect of diaphragm pacing so far. Numerous animal models, canine, swine, rats. I have multiple IRB protocols and IDE protocols for this. There's been over $60 million spent on this project. Over 2,000 patients have been implanted with this type of technology worldwide in 28 countries. My own institution, we've done over 700 implants. Obviously, I've had multiple publications and book chapters on this topic. It really comes down to how do we breathe? We all know we breathe based on our prebascular complex, our lateral medulla. Most of us don't think about breathing. We know we can use our cerebral cortex to breathe. Then it kind of goes down from that trackways to our lower motor neurons at C3 to 5, the spinal cord. And the phrenic nerves have to be intact, and your diaphragm motor units. If a patient has lost control of their upper motor neurons, that's where diaphragm pacing can overcome. We also have a strong evidence on the diaphragm pacing to help prevent ventilator-induced diaphragm dysfunction, maintaining diaphragm strength, and a lot of data now on recovery from an injured nerve. And I'll share a lot of this with you today. The objectives really is to talk about both the chronic system, which can be used up to 20 years, which is the NeuroRx. It's used in spinal cord injured patients, injured phrenic nerves, central sleep apnea, neuromuscular diseases that we'll talk about. And then the temporary system that got FDA emergency use authorization in April of 2020. It also has European CE mark approval. And this is for use for less than 30 days. It can be placed at the time of a laparotomy, a sternotomy, a thoracotomy, laparoscopically or thoracoscopically. And that can be removed when you're done. It's actually a great way to help maintain that diaphragm strength. And really what it shows and what we're trying to show is what can occur is when we're doing this for our chronic system, we check the diaphragms. And you can see here, this is a laparoscopic view of the right diaphragm. Right now, you can see nothing's happening. Then we go over and look at the left diaphragm. This is a complex patient who had a gunshot wound to the neck where the right phrenic nerve and motor neurons were damaged. And look at the left side. Great movement. And again, that's what can happen. This patient had been on a ventilator for 5 years. That diaphragm can still be stimulated. We've developed a way laparoscopically to identify the motor point, the best spot for contractions. We then place electrodes in the diaphragm. We place 2 electrodes on each side, as you can see in this video here. Then we can stimulate the diaphragm. Again, the anterior diaphragm, you'll see contracting here, and the posterior diaphragm, and the entire diaphragm. We place these electrodes to drive diaphragm contraction. Therefore, that drives ventilation for patients that need the chronic system. And then we program the device. The device is a percutaneous device, even for our chronic patients. And we can maintain that tidal volume, allow the patients to breathe throughout the day and night, 24 hours a day. We program the patients to give the best tidal volume at the best rate for these patients. In pediatric patients, we can go a much higher respiratory rate than adult spinal cord injury patients. Easy enough to program what the patient needs. It's almost like programming that ventilator that you're all so familiar with. This is the new temporary system. This is a video showing how the electrodes can be placed at the time of a median sternotomy. There's 1 electrode already in the diaphragm, then placing a separate 2nd electrode in the diaphragm. As you can see, it can be done in open fashion. These are new temporary electrodes that work very well to be placed at the time of another operation. And then we bring them out percutaneously, just like you would a temporary cardiac pacing, which is put in just about every open heart operation that's being performed. And so you'll have 2 electrodes on each diaphragm. And you'll bring them out just like the temporary cardiac electrodes that are here. Again, identifying a way that we can place these temporary electrodes for high-risk patients. In 2020, obviously, as we all know, throughout the entire world, the COVID pandemic changed what we looked at. And so my experience in diaphragm pacing, both the chronic system and the acute system, kind of changed as we looked at any way to get any patient off the ventilator faster at my institution. And so I implanted 125 patients in my institution last year, 64 patients with the chronic patient system. I'll kind of go over each one of these groups a little bit, but they go from idiopathic phrenic nerve dysfunction, spinal cord injured patients, bilateral diaphragm dysfunction, just to wean patients. And then the temporary electrodes in 61 patients. Most commonly, this was done through a median sternotomy with cardiac procedures. During our peak of our pandemic, we were only doing emergency cardiac cases, so they're all high-risk cases, lung transplants, heart transplants, and several COVID patients. It really goes back to diaphragm pacing. It really started with my research to spinal cord injured patients. The first patient we ever implanted was in 2000. We all know the problems if you're a high quadriplegic. Many spinal cord injured patients require intubation. We know that the leading cause of death in spinal cord injury, if you're on a ventilator, is pneumonia. We know it's extremely expensive to be on a ventilator. We know it changes everything. And here you have a picture of my second patient I ever implanted, Superman, or Christopher Reeve. We've published a lot of our success, and I'll just share with you some of our most recent articles. This is one from 2018 showing 92 of my chronic patients that we implanted, spinal cord injured patients, showing that we can get many of these patients off the ventilator at least 4 hours. Again, depending on your injury of your spinal cord, it may not work in everybody. And I'll talk a little bit more about that later. But we do know it definitely improves survival in these patients. One of the interesting things we found early on is that we can actually read our implanted electrodes. I can see when a patient recovers breathing. We know that electrical stimulation or physical therapy helps a spinal cord injured patient recover. We know that by stimulating the diaphragm, we can help a patient recover their own breathing. And as you can see, I can see the EKG artifact, and I can see recovery of the patient's own breathing. This is without stimulation. This can occur a while after the injury as they relearn pathways around that spinal cord injury. You'll see a lot of this because reading these implanted electrodes has really become what we do in all of our patients to look for our results in these patients. There's a patient that we can show how early we can do this without a tracheostomy. Patient who had 16-year-old injured in a wrestling accident, 21 days on a ventilator, transferred to my institution. I implanted him, extubated him 2 days later with no tracheostomy. We subsequently, as you can see here, he got recovery, and we pulled these chronic electrodes we can still remove. This is a very happy gentleman who says no scars on my neck, no adverse risks of that tracheostomy. When the patient's in bed for that first 21 days, no rehabilitation is being done on that patient. Getting off the ventilator is everything initially in these patients. This is Dr. Kerwin, who from Florida kind of talked about going from the usual 61 patients to diaphragm pacing. What he showed is that early mortality rate went down. That's significant because the longer you're on a ventilator, the greater chance you get for pneumonia, the greater the risk for death from that pneumonia is. He showed how many ventilator-associated pneumonia days went down once you went diaphragm pacing. Length of hospital stay went down. Again, more data showing that you can decrease mortality and the length of hospital stay. He also showed how, again, the amount of time on the ventilator in another group of patients, 37 diaphragm pacing and 34 without, time to ventilator reading 10 days from 30 days. Huge change in the management of a spinal cord injured patient in our acute trauma hospitals. And he actually looked at the cost savings. Again, we know the cost savings can be significant. Every day that you're in the hospital, especially if you're in ICU, is extremely expensive. He showed the cost savings of $150,000 US by using diaphragm pacing early per patient. So we've shown now that, one, we improve survival. We've shown that we can save money, decrease ICU days, decrease ventilator days. All these things are so important in our early trauma patients with spinal cord injury. We've shown other results in the past about decreasing pneumonia rate. This is a study out of Europe showing, on average, if you're a spinal cord injured patient on a ventilator, you get 2 pulmonary infections a year. When you get off the ventilator with diaphragm pacing or phrenic pacing, it goes to 0. This is just an example of this. This is one of my own patients with a elevated right diaphragm, right lower lobe collapse. And actually, he could move one diaphragm and not the other diaphragm. He's a spinal cord injured patient. We added pacing. We can clear out that atelectasis, no longer an elevated diaphragm. Again, all this data that we can show. And actually, some of this early data led me to many of our other aspects of our research. One thing that I did publish, many times people think, how do you know if you can implant these patients? Do we need a phrenic nerve study? We've shown now on this study that I published just this year that no, the best thing to do is to go to surgery and look laparoscopically. You can have a false positive where you think you can implant this patient, but more importantly, you have a false negative, or that phrenic nerve study that wasn't positive, but when we go in at surgery, we can stimulate the diaphragm. So again, in a patient on a ventilator doing a diagnostic laparoscopy, it's not that risky. And if you can get that patient off the ventilator, it really changes their life. And this is what I mean by changing the life. This is a teenager who was intubated on bed rest for 6 weeks. He was transferred from Kuwait to me in the United States. We implanted him, extubated him. He was an incomplete spinal cord injury patient. Here he is learning to walk again, diaphragm pacing in his pocket. Again, if you can get a patient off the ventilator, the rehabilitation is so much better. And again, this is the critical aspect of early diaphragm pacing. Patient recovers breathing, we can then remove these electrodes. Now, the pediatric applications, you've seen several of my pediatric patients. Initially, the first time I published this was on patients until the FDA allowed me to start working in children. I published a group of 11 spinal cord injured patients who were injured as children, and I implanted them as adults, showing it was worked many years after that. And then this is my first publication of my first 6 patients, pediatric ones that we implanted. And since then, we've done a whole series of other indications, including acute flaccid myelitis. Well, I'll kind of talk about these other indications now. But first, I want to talk about some of our excitement in the NICU. We've been looking a little bit on, can we help patients who've lost diaphragm function? Again, this is my first patient in the neonatal intensive care unit that we implanted. Again, no movement on his diaphragms. You can see his feeding tube, his tracheostomy, our pacing wires coming out. We could read this activity, no activity. And then he started recovering his activity. Then we removed his tracheostomy. So again, helping somebody with some reason with lack of diaphragm control. And again, we'll do a lot of work, and I'll show you on our next patient also. This again, an ultrasound showing no movement on the right diaphragm, some movement on the left. And you can see me checking at surgery. Here's just the right diaphragm. And then all of a sudden you'll see me stimulate. You'll see a nice big contraction. So we can stimulate that diaphragm. If we can see that at surgery on this 8-week-old, 4-kilogram child, we can implant these electrodes and help maintain that ventilation on these very small patients. What was so exciting on this patient is initially we had very little diaphragm. This is the left diaphragm's activity. This is the right diaphragm. And really a lot of apneas when patients on a ventilator, no diaphragm activity. But on day 10, when we turn off the pacing, we start seeing good burst activity on both sides. We're actually able to wean this patient off the pacer, wean them off the ventilator. Again, that really changes our management in the intensive care unit, where we look at what is one of the problems. Is there a lack of ventilation on these children that we can overcome? We've done a little work with Pompeii's disease. You think it's a primary muscle disease, but as I've said, we started identifying a lack of muscle control. The preboscular complex, the lateral medulla, can be affected. In this study that we published, as patients were getting their enzyme replacement, we added diaphragm pacing, and the patients were able to recover even better and get off the ventilator. Done some work in SMA2 patients. Again, a patient with no activity, had intubated. We put in the diaphragm pacing. We identified, even though SMA2 should be a lower motor neuron disease, the phrenic motor neurons were intact. We weaned this child off the ventilator. It was an 18-year-old. Again, that's usually when they go on the ventilator. And I've done a second patient. So again, there's a central component in many of these pediatric neuromuscular diseases where diaphragm pacing can overcome that lack of control for them. I'm going to talk a little bit more about this idiopathic. You showed or unilateral diaphragm dysfunction, or bilateral, that patients lose control. Again, I showed you a picture of one of my spinal cord injured patients. By 2014, I already was looking at a series of patients. My first publication on this, where in this group of 20 patients, we had 86%. We got recovery of that. We were able to wean some patients off the ventilator that had been on a ventilator for a number of years because of diaphragm dysfunction from a phrenic neuropathy. Again, this is an example, very elevated diaphragm, normal. Patient can move. EMG activity on the right, nothing on the left, recovery. So this goes down to a lot of our research on electrical stimulation, helping nerves recover and controlled recovery of that diaphragm. We presented this last year at the virtual ATS conference. We're up to 62 patients with about 71% recovery of that unilateral diaphragm paralysis. Again, adding something for these patients. Once you plicate a diaphragm, that diaphragm will never work again. So we've really changed what we look at, and we've gone away from diaphragm plication, at least giving a chance for functional recovery of that diaphragm. Now I'm going to talk a little bit and kind of close out talking about temporary diaphragm pacing. Since the New England Journal article in 2008 showing that how rapidly the diaphragm's atrophy, how rapidly it converts to type 2B muscle fiber, numerous studies have repeated that. And we know there's, in the United States, 400,000 patients have mechanical ventilation. We know that this became a problem because our ICUs got filled with COVID, along with our usual patients for that. We know tracheostomies have a significant complication risk. In the United States, it's extremely costly for chronic mechanical ventilation. In every one of your countries, I'm sure you have many chronically ventilated patients during that recovery. Can we help them get off the ventilator faster? And I also looked a lot at cardiac surgery as a good model for that. We know that in cardiac surgery, after an open heart operation, 12% require mechanical ventilation after 24 hours and 4% after 5 days. And it's a good study because that database on them is so well looked at that we know that infection rate goes up. We all know that if you're on mechanical ventilation, the cost goes up. And can we change that? And I started doing a lot of look into that. So I started using our chronic system on patients who had phrenic nerve injuries after open heart surgery. We showed that we could help 9 out of these 10 patients. We presented this in 2018. We know that we can improve the survival. If you're on a ventilator after an open heart operation, your 1-year survival historically has only been 30%, because that's how severe being on a ventilator is for these patients. Our 1-year survival was 80%. And we actually went up to 23 patients in 2019. We presented a much larger group showing with our chronic system, we could help these cardiac patients. In this time frame, we're looking at, again, this is a perfect example of a patient who had the left ventricular assist device, injured phrenic nerves. Again, showing on these diagrams, recovery. So our electrodes can stimulate and read, and we know the patient recovers. Now this patient is a candidate for a heart transplant. Again, we had a lot of this evidence, what we're doing, that led us to, at the same time, start looking, could we put these electrodes in high-risk patients? temporary electrodes. And this is our publication in 2018 of our initial study ID showing that one, we can implant them. We don't need to do that mapping because we can see where it's at. We can get a tidal volume over 137% predicted of these patients. So we can stimulate enough to ventilate these patients, placing these electrodes at the time of an operation. We showed in this study that we could do it during laparotomies, laparoscopies, median sternotomies. And again, it showed the ease of placement and removal, complete removal of these electrodes. So we now had a way to get to the diaphragm during another operation and actually perhaps put them in at the time period. And really, the COVID pandemic kind of showed that we could do that. So in last year, in April of 2020, our temporary electrodes were FDA authorized and we started placing them. This is a great example of a patient, emergency open heart, waiting for liver transfer. This is a temporary system, typical median sternotomy with 3 chest tubes. Patient was in a hepatic coma while waiting for liver transplant after his emergency heart bypass. We just had him on CPAP with the diaphragm pacing. So we can just manage that diaphragm on a patient that had no activity or because of their coma until they got the ventilator. So we're preserving both the diaphragm and really the lung, ventilating the lung. We actually did a pilot study of this group in an IDE, clinicaltrials.gov. And I'll kind of share with you results, and this paper should be coming out shortly. Our primary endpoint showed we could place them during these high-risk cardiac electrode patients. We could remove these electrodes. We could read EMGs. And then we can actually stimulate them and help them get off the ventilator. So in conclusion, we showed that during these cardiac patients, it's feasible. We can definitely improve diaphragm function and ventilation, increase likelihood of extubation. Now we're doing a randomized trial in 40 patients, randomizing them to immediate use before we're waiting for 24 hours to see if we can shorten that entire time. Patients on a ventilator in our ICU post a high-risk cardiac case. We actually presented another group of patients with known preoperatively elevated diaphragms on a ventilator beforehand. And we showed and presented at the Society of Thoracic Surgeons last year, a group of these patients showing that we could, by adding diaphragm pacing at the time, we could just very rapidly wean these patients. So we're getting this evidence of these temporary electrodes at the time of cardiac operations. Again, this is an example of a patient having an emergency elevated BMI on BiPAP pre-op, elevated right diaphragm. And we implanted the electrodes at the time of the operation. He was extubated immediately. This just shows how we remove these electrodes. Very simple to remove. Again, we are doing more looking at this. Thoracoabdominal aortic aneurysm repairs with a major thoracoabdominal incision. This has been presented at a series of these patients now. We can now actually measure in these patients how the diaphragm gets stronger with the patients. The power density spectrum shows by pacing them. This is, again, high-risk patients, an infected aorta, a major operation on bypass. And again, we can implant these electrodes at the time of the operation, pace them immediately. We showed in all these patients, we're able to very rapidly wean them off the ventilator, maintain that diaphragm strength for them. And also at the same time period, I've been looking a lot at lung transplants. And again, a group out of Europe showed their work at the time. We know that at the time of a lung transplant, there's a very high incidence of phrenic neuropathies that occur in diaphragm dysfunction. And so we showed at this initial report that we can place them, we can read EMG, we can pace these patients. Led to our initial presentation with our chronic system at ATS 2020, 3 cases out of Oklahoma, where the phrenic nerve was injured, and we can overcome the morbidity of the phrenic nerve injury by adding diaphragm pacing. Kind of our conclusion there, interesting, was the future may involve placing temporary electrodes at the time of the primary procedure, which we subsequently did. So we now had, with a Transaris now being available, we can place them at the time of lung transplant. It allows us, and we presented this at the heart-lung transplant meeting just this past April on a group of 8 patients, 4 with the temporary and 4 with the chronic system, because that was kind of looking at patients with phrenic nerve injuries and those patients that we implanted. We now have a much larger series of lung transplant patients that we're presenting at a future meeting also. What we showed in this group of patients that we can identify phrenic nerve dysfunction early. 2 patients had normal diaphragm EMG activity, easily extubated. 2 other patients had significant bilateral phrenic nerve dysfunction. And actually we started pacing them. We could look within that first day, we could predict, and in our next 10 patients, we continue to be able to predict if they're going to be a difficult wean or an easy wean. In COVID-19, it's been very difficult. As we all know, COVID-19 mostly affects oxygenation for these patients. But there is some patients that with the long COVID get a neuropathy. Again, you'll see on this video here, a patient trying to breathe with, I love doing sniff fluoroscopies, can't move his diaphragm at all. We've implanted several patients with this where we can help that neuropathy recover after their acute oxygenation problem's over, trying to get them off the ventilator at that point in time. So it's been a very limited utilization for this because as we all know, when you really get on the ventilator and you have such bad oxygenation, your overall survival is fairly poor. And so, but we have been looking at this on a subgroup of patients. And I know I wish I was in person with all of you and I kind of go to my conclusions now. I know I talk fast. I think sometimes I talk faster on Zoom than if I was in person with you, because then I could look and see what was going on. But I hope we'll be able to talk and discuss this here a little bit while you're finishing your meal, if that's what's occurring. And really, it's pretty straightforward. All spinal cord injury patients should have an implantation. The data is overwhelming for these patients. The quality of life changes significantly for them. And when I look at pediatric indications, and really in our pediatric intensive care unit, now in our NICU, we start looking, why can't we wean this patient? We'll do ultrasounds. Patient can't control the diaphragm. Why is that? Can we add pacing to help them get over that hump? And so it's really been exciting as we look for these indications. We know in Pompe's, acute flaccid myelitis, SMA2, we have very good data on that now. So it's something to look at on your patients. Why can't, is it lack of that drive for ventilation? And we know in high-risk cardiac patients and lung transplant patients, then temporary electrodes really can change how we manage them perioperatively. To identify patients that will be difficult to wean, to help them if we identify that nerve injury early, all the data shows that. And really what we start looking at is anybody that we're thinking about tracheostomy. I'm a surgeon, I do tracheostomies. I know there's a risk with tracheostomies. I've seen patients with chronic tracheomalacia, which we have no good therapy for. We know we can have bleeding. We know there's a death rate for tracheostomies when we look at the data. And so one, can we look at diaphragm pacing to add to these patients? That's something that we're all really looking at now and helping any patient we can get off the ventilator, since we know the difficulty with chronic ventilation that we have, even acute ventilation, the lack of ventilator beds and what's occurring worldwide now is just heartbreaking. If we can do anything to help get patients off, to open up another ICU bed, that's important to offer to people. And again, it's a fairly simple concept. I mean, if you move the diaphragm, you're going to improve ventilation. It's something we've really been looking at for a great period of time. And again, I know my patients are part of research. And so whenever we all do research, after a year, I have to say, hey, do you want to go back to the ventilator, not do diaphragm pacing? And fortunately, all these patients that I've had for 20 years of doing pacing, nobody says, you know something, I really like the ventilator. Using your own muscle for ventilation really helps and will help significantly. My email is down here, and please feel free to email me at any time, raymond.anders@uhhospitals.org. And it's been great. I wish it'd be in person, maybe 2022. Again, reach out if you have any questions, as we all try to figure out ways and collaborate on working on helping every patient get off the ventilator. Thank you, and I wish you all well and be safe.
Thank you. Thank you. Your amazing talk and a good result, Dr. Owner. And because the time is limited, because the lecture is delayed, so we just open for 3 questions for all the audience. And there are one question about come from Angle. He said the electrode will have the lifespan. How do you monitor? You will need to replace this electrode.
That's an excellent question. And again, thank you for allowing me to speak with all of you today. I wish it could be in person. One is we check the resistance every time we pace the patient for every breath, so we know if the electrode would have a problem. Fortunately, these electrodes designed by my university actually have an incredible lifespan. We've been using them for every minute of every day for up to 20 years now without a problem. When I designed this, I did design 2 electrodes for each diaphragm, so we always have a backup electrode if needed. But so far, the electrodes have been very successful, not having any problems for replacement. But we do measure the resistance electronically, so if the problem would develop or electrode would have a difficulty, we could know that before there's a problem for these patients.
Thank you. Thank you, your answer. Another question is come from Dr. Bill Chun. He said, does the utilization of temporal diaphragm pacing is increased during this kind of the COVID-19 pandemic? And I have another question for this one, because you have a good presentation for the last case of the COVID-19 related neuropathy and or myopathy. How this patient is he recover or persistent?
Our data for injured phrenic nerves is very strong, or a neuropathy. So we all know that physical therapy will help a nerve recover. As we all know, it's hard to do physical therapy of the diaphragm if you can't move your diaphragm. Adding the electrodes actually helps that diaphragm recovery, which actually helps the nerve to recover. There's an afferent effect when you do distal muscle stimulation that it'll actually help that nerve recover. So, my biggest experience is in idiopathic diaphragm pacing, because we'll have patients with a unilateral elevated diaphragm, like that NICU patient I showed you earlier in the video. That actually helps the nerve to recover, and then the patient can breathe on their own. Then we just pull these electrodes. It goes back to the concept of everybody undergoing an open heart operation has temporary cardiac pacing just in case. Adding these electrodes at the time of another major operation is easy to do. You kind of have a safety because we can now read it. I like the NAVA where you're reading EMG. We read the EMG with our implanted electrodes. We can tell if the patient has the apneas. If the patient has apneas, we can start pacing to prevent that atrophy of the diaphragm, maintain the entire respiratory system by pacing the diaphragm directly.
Thank you. Thank you, Dr. Olden. Another question come from, come from the Dr. Chen. You already presented this question in the video. He said, can spinal muscular atrophy patient use diaphragm pacing? So I saw you show in the video. So I have another question, because we know the iatrogenic injury always induce the unilateral diaphragm paralysis. Is this kind of pacing can use for the rehabilitation for this kind of patient?
Absolutely. As we all know, in lung transplant, where I'm doing a lot of research now, when you explant a fibrotic lung, there's a high incidence of temporary diaphragm injuries. What we can do at the time of a lung transplant, we can place these electrodes while we're there. Therefore, we can monitor for that injured nerve. And as we all know, if you can't move your diaphragm, you're not going to ventilate the lung appropriately. Our diaphragm causes ventilation in the posterior lobes of the lung. As we all know, mechanical ventilation doesn't really ventilate the entire lung well. So by driving the diaphragm, even with an injured nerve, we can cause that diaphragm to contract, will help the ventilation of that lung. And that's kind of, we know in redo open heart surgery, we know in difficult pediatric open heart surgery, there's this instance of phrenic nerve dysfunction. Adding the ability to do physical therapy for the diaphragm, that's really what these temporary electrodes is. It's aggressive physical therapy for that diaphragm when it can't contract on its own. That helps the nerve to recover. There's some incredible data now on distal muscle stimulation helping nerves recover after injury. That's the benefit of at least having these electrodes available postoperatively after you've had an injured phrenic nerve.
Thank you. Your excellent answer. Because this is so delayed, so and we have a limited time, so I must close this discussion. And thank you again, Dr. Olden. And this is the end of today's conference. So see you guys tomorrow, and good night.
Thank you so much for having me here. It's wonderful to talk with all of you.
Bye-bye.